Hello everyone. Today I'm talking about a topic which is very important, and the name of the topic is hepatitis B in pregnant women. This is the first topic which I'm going to share on my channel, and I have taken this information from Up to Date. I have taken an algorithm from them and write it in my own words to just memorize it and share with you, all of you. Let's start. So if a patient is coming, let's suppose take a pregnant woman is coming to us in the first trimester, we always check their hepatitis B status by checking the surface antigen. If it comes negative, then we are not worried about anything, and we go with all the other trimester blood work as well as other necessary investigations to till the end of the delivery, because when the delivery is happening, we don't have to worry about, and when the infant is born, we just give the scheduled hepatitis B vaccinations to them. Second thing is, definitely if a patient comes to us and she is having positive, then how we can manage it. But I just want to divert you guys to one more important thing, that sometimes we have pregnant women who are negative, but they are a high risk. What does that means to us? So let's suppose, take this example here. If pregnant women come to us and this give us a negative, then it's very good. We go with the hepatitis B vaccination for infants at the scheduled dose. In case if we know that mother is high risk, for example, she is HIV drug user, IV drug user, she is sexual partner with the people, like multiple sexual partners, or maybe her sexual partner is having chronic hepatitis B virus from before. So in that case, what we have to do, one more important thing which we have to make sure is, we are not just staying onto the surface antigen, we have to go towards antibodies. So here we will be checking antibodies of surface antigen as well as core antibodies. So we are going to check three things. But if a patient is high risk, number one, checking surface antigen, number two, checking surface antibody, number three, checking core antibody. And it is all happens when we know that the patient is a high risk in terms of maybe drug user, which is IV injectable form, her sexual partners are having any conditions, or she might be having multiple sexual partners. Then if we do not find any evidence of these three steps, for example, her surface antigen is negative, there is no surface antibody, there is no core antibody, now our step is to vaccinate mother if it is not vaccinated before, surely. And we are going to repeat her surface antigen in late pregnancy, that is about 28 weeks. So the only important thing is, if a patient is high risk, she comes to us in first trimester, we check everything, nothing is there, we go with the smooth pregnancy. But during the late second trimester, that means 28 weeks, we have to repeat her surface antigen. Okay, and at the same time, in the first trimester, we used to vaccinate the mother. This is all about high risk. Now let's come to the pregnant women who have positive surface antigen on the first trimester. So we check the baselines, that is liver panel, like all the liver enzymes and everything, as well as DNA level, as well as hepatitis E antigen and E antibody, because as everybody know that B comes with E, so we just want to make sure that the patient is having E or no. If in any case aminotransferase is elevated, DNA level of hepatitis B virus is more than 20,000, 200,000, I'm sorry about that, and or their E is positive, especially antigen is positive, then we have to refer the patient to the hepatologist. Now the work is going from family physician to specialist. but at the same time, it is our job to follow up, right? So we do repeat it. What? DNA level, liver panel at the 28 weeks. If DNA is more than this unit, that means 10 raised to power 6 copies, then we should offer mother an antiviral therapy, and it also happens in 28 weeks, up to 28 to 30 weeks. And when the child is born within 12 hours of birth, we should initiate hepatitis B vaccination, as well as we should give immunoglobulin to the child. If DNA is less than the unit 200,000, then we are going to say that okay, still we will be giving everything to the child, but we are not going towards the antiviral therapy of the mother. So in this case, we are going to give 12 hours, within 12 hours of birth, we are going to give uh, hepatitis B vaccination and immunoglobulin. Now, the series, as you see, I have mentioned here the word series. So that means we are going to give doses on multiple times, maybe 2 or 3 or something. When we used to give first, when mother is positive, maybe mother is unknown. When father is a known positive, then our follow-up dose is going to be 1 to 6 months. This is all about hepatitis B in a pregnant patient. If it's negative, if it's positive, if negative, along with the high risk, what we have to give. Only one thing I want to show you, which I missed before, is anti-surface antibody. If it's only present in a person, that means she might be previously vaccinated. But if core antibody or surface antigen is present, that means there is something different. How about breastfeeding? Maybe mother is pregnant, she did not take her treatment, she didn't come for vaccination. You give vaccination to child because mother was unknown at the time of delivery or something. Everything can happen. In any case, we cannot restrict a mother from giving the breastfeed to a child, because we can say that breastfeeding is safe in a mother who is hepatitis B positive. Same as go with the vaginal birth. If mother is hepatitis B, for any reason she took the medication, she didn't took the medication, or there may be any case, but we need to make sure that we do not say that vaginal delivery is contraindicated, because vaginal delivery is safe, breastfeeding is safe in these cases. So overall, what we have learned today, 3 things. Number one thing, if negative, okay, but if high risk, we should be going towards more investigations. And if in any case she is high risk, everything is negative, we should repeat the surface antigen at 28 weeks. If it's positive, let's check about do we need to go to the specialist or no, as well as we are checking about hepatitis E also. If DNA is this unit 200,000, then we have to start viral therapy, as well as give a child hepatitis B vaccine series and immunoglobulin. But if it's less than this unit, we might only talk about infant. We are not going towards a mother. So this was today's topic. If you have any questions, or is there anything which you want to give on feedback, I'm more than happy